of medicine, especially in rural settings, where obviously anything can come through your door, but you might not have the same resources as in one of your big centers. And we're very pleased to have with us here tonight Dr. Pieter Jordan, who's actually coming to us from George. And Pieter is an orthopedic surgeon. But he's actually super specialized in, or what they call the subspeciality, and it is training in the UK in hand and peripheral nerve surgery, and also then completed his European Hand Diploma in 2021. And there's not actually many orthopedic surgeons in South Africa that has that subspeciality specifically in hand. So we are hands. So we are very pleased to have one of the foremost hand orthopedic surgeons here tonight. And the hand, of course, injuries to the hand are one of those things that is very important to manage well early on, because as human beings, our hands are actually such an essential part of being able to get things done. And even small injuries to the hand can actually be very disabling in terms of even simple things like daily activities. And so getting that right from the beginning is very important. And so we're very pleased to have Pieter here with us this evening. So I'm going to hand over to him without any further ado.
Hi, good evening. I'm just going to share the screen and then I think let's get going. Um, great. Okay, great. Is everybody can see that, I hope. So the title is It's Not Just a Finger, and you'll see why as we go along. And I think we traditionally, when I started, most people would, if somebody injures their hand, they'd say, "Oh, it's just a finger, don't worry about it." But it's definitely not just a finger. And it's important to remember that everyone's hands are important to them. I mean, I just do hand and peripheral nerve surgery, and occasionally patients walk in and they say, "Doc, my hands are really important to me." But at the end of the day, everyone's got to eat and everybody's got to go to the toilet, and you need your hands for that. So hands are important for everyone out there. The other thing, just before I get to the nitty-gritty, is there's this theory or this feeling that somebody says, "I can move my finger, it's not broken." That's a myth. So forget about that. I will discuss that in a bit more detail later. So, I mean, when I start something like this, I can't help to feel a bit like Gandalf. This is a massive topic, and we actually don't have that much time. So that's why I'm going to try and go through things as quickly as I can. And I'm going to try and cover quite a broad field in hand surgery. And I'll skim over certain things. So you're welcome to ask questions at the end. So I think in hand anatomy, it's really important to know your basic anatomy very well. And I will go through some basics that you might have already forgotten, but I think it's very important to remember. As I go through this talk, the most important decision you need to be able to make is, do I refer this or do I not refer this? Can I manage it myself or must this be referred? So with every case I go through, just think about it and I'll try and highlight what you can manage and what must be referred. I'm going to discuss open injuries, just a broad approach, because open injuries generally need to be referred for surgical management. Closed injuries, most of them can be managed conservatively, so we'll discuss about that a little bit. I'm going to briefly talk about sepsis, very, very important in hands, and I'll try and give you a few tips and tricks and basic things that are just good to know regarding hands. Very important, you must know your anatomy when it comes to the hand. Generally in orthopedics, it's important. In the upper limb, it's even more important because you've got nerves, you've got tendons, there are joints, there are arteries, there are lots of things, and you must know how to examine for it. You must know how to test for it. So I'm not going to go through all the examinations. It's very hard to do that in this limited time. But just regarding the nerve, so I am a bit of a nerve nerd, so I will spend a bit of time talking about that. But I want to give you some easy ways just to remember which nerves supply which muscles. This is important when somebody arrives with an injury, for you just to try and see, what have they injured and have they injured something. So median nerve, you all know the sensory pattern. You'll see there in the bottom right-hand corner is a nice diagram. Basically, the thumb to the radial side of the ring finger. Just remember that only about 40% of patients have this nerve supply that we were taught at university, but it's the most common variant, so that's why it gets taught. But the majority of people actually have multiple different variations. But an easy way to remember the motor supply of the median nerve is it supplies all the muscles in the forearm except your FCU and the ulnar-sided two FDPs. And in the hand, it only supplies loaf. So your radial two lumbricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. So that's the median nerve. Just below the elbow, it gives a big branch off, which is the anterior interosseous nerve. That specifically supplies the FDPs, the radial two, the FPL, and the pronator quadratus. The reason why this is important is just depending on the level of injury, you can't, let's say, have a stab wound low down the arm and you check your thumb flexion and say the median nerve is intact. You've got to then test your intrinsic hand muscles that's applied by the median nerve. The ulnar nerve sensation you also know very well. Just remember that the branch that supplies sensation to the dorsum of the ulnar side of the hand actually branches off about 7 centimeters before the wrist. So a nerve injury at the wrist will leave you with intact sensation on the dorsal aspect of the hand there. So motor function, so median nerve, remember all the muscles in the forearm except for FCU and the ulnar two FDPs. Ulnar nerve, all the muscles in the hand except for loaf. And then, as I said previously, FCU and the ulnar two FDPs. Radial nerve sensation, dorsum of the hand on the radial side, that area there. Motor function is all your extensors. So basically, the radial nerve proper supplies brachyradialis and ECRL. After that, the radial nerve branches, and you get a sensory nerve, and you get the posterior interosseous nerve, which is, well, not purely a motor nerve, but mostly a motor nerve. So your finger extensors are all supplied by the posterior interosseous nerve. So if somebody has an injury to the posterior interosseous nerve, their radial nerve sensation will be normal, but they won't be able to extend their thumb and fingers. Just a brief note about sensation in the forearm. This will help you to differentiate between potentially higher lesions, so other words, neck injuries, and peripheral nerve injuries. So the lateral side of the arm, the forearm, so in other words, this side, the radial side, is supplied by the lateral antebrachial cutaneous nerve, which originates from the musculocutaneous nerve. That's the nerve that supplies biceps and brachialis. The ulnar side of the forearm, that side, is supplied by the medial antebrachial cutaneous nerve. That comes off the medial cord of the brachial plexus. The posterior part of your forearm there is supplied by the posterior antebrachial cutaneous nerve. That actually comes off the radial nerve, but it branches high up in the arm. So just remember that the median nerve and the ulnar nerve has got no sensory innervation in the forearm, only in the hand. So just keep that in mind. If somebody's got sensory fallout in the forearm, it's not from the median or ulnar nerve that's injured. So getting on to the open injuries, this is where knowing your anatomy is so, so important, because if you know what structures are there, you will know what structures can be injured and you'll know what to look for. So just as an example, that photo, it was a circular saw that cut through this gentleman's hands. If you know there are nerves, there are arteries, there are tendons, and there are bones, then you know what injuries to look for. Maybe in your setting or the hospitals you refer to might say, oh, they don't fix digital nerves. I mean, generally in the hand, we fix digital nerves. So if somebody's nerve is cut, we fix it. If you look at that photo, you'll see his fingers are slightly bluish. We call it the turgor is poor, so he doesn't have a nice puffy fingertip. It looks like it's slightly collapsed. That's because both arteries are cut. And that's important to look for, because even though he's got capillary refill that looks all rightish, it's not normal, and this patient needed his digital arteries repaired as well. Remember to do your neurovascular examination before you inject local anesthetic. It's no point injecting the local anesthetic for pain relief and then examining them for their sensation. Always examine motor function, as I said, capillary refill and turgor, and always actively look for tendon injuries. Sometimes they might move well, but if you test the tendon against resistance, they'll be painful, it will be very weak. And that's usually an indication that the tendon is off or partially off and probably needs exploration. And as I said previously, it's not just a finger. And for me, that includes have a very low threshold for performing x-rays. And actually, in trauma of the hand, just always do x-rays. I know a lot of you don't have access to x-rays or only have access during the day. Where I did my internship in ComServe, we were not allowed to call out the radiographers after hours unless it was a real emergency, but then just get the x-ray the next day. And for instance, this was a dog bite, came into casualty, they just stitched it up, came back looking like this, and underlying the dog bite, there was a fracture that wasn't clinically suspected. And now 3 days down the line, you've got a open fracture that's septic, which is a big problem where if initially it was the x-ray was done, the fracture would have been picked up and it would have been treated surgically from the start. So remember that. General management for open hand injuries. You guys all have done your ACLS, I presume. Remember, it's still life before limb. So you're not going to save the arm if the patient's going to die. Analgesia is part of your emergency treatment. So it's really important to give somebody good analgesia. And for that, often in the hand, you can block it. Just do your neurovascular exam before you do the block. If the limb is malaligned and you've got decreased perfusion, realign it, stabilize it, and reassess it. Often just realigning the limb will improve the perfusion. Always remember IV antibiotics. Early IV antibiotics is probably your most important thing that you can do in terms of preventing infection. For most wounds in the hand, Kepsol is fine. For the severe injuries, Augmentin is probably good enough. You don't have to give triple antibiotics. Check the tetanus status, sort that out. Wash out the wound thoroughly, and often they need a bit of a debridement. You can cover it with moist saline dressings. If the wound is not contaminated, let's say it's a laceration and the tendon's off and you're going to refer it to a referral hospital. If it's clean and there's not a lot of soft tissue damage and you've washed it out, it's fine to put 1 or 2 stitches in the wound. But I always tell people, check with your referral hospital what they prefer. It's no point I tell you to do things in your referral hospital as a different protocol, but it's generally okay to just put 1 or 2 just simple tacking sutures in and always splint the limb. The splintage helps a lot for pain relief. The mangled hand, just again, obviously this will need to be referred, but in terms of your basic management, it's the same as your general management to the open hand. If there's going to be a delay in transfer and you can anesthetize the limb properly and you've got the facilities to take it into a theater setting, wash it out properly. Really give it a good washout. Remove foreign bodies that you can. If you can see there's no vital structures, you can do a basic debridement of the wound to try and just decontaminate it. But remember, the arm's got tendons, it's got nerves, it's got blood vessels. You don't want to cause more damage. So if you're not sure, rather just give it a good washout, realign it and splint it and then refer it on. Obviously, a replant, so emergency transfer, you're not going to manage this on your own in the periphery, but urgent transfer is very important. Fingers and hands can be reattached successfully. So if you see something like this, cover the open wound area in a moist saline swab, not wet. You don't want it wet because then it becomes macerated. Then you place the limb in a sealed plastic bag and you put it in ice water. Don't put the limb on ice. On ice, you will probably damage the tissue, but in ice water is fine as long as it's sealed and you don't get a macerated limb. It's quite important because managing this correctly means the difference between somebody losing a hand or a finger and saving it. Obviously, single finger replant is controversial, and in your settings, it'll probably not happen. But, multiple fingers or hand replants, just manage it correctly from the start. Then, these are things that you can do in your setting. If you've got fingertip injuries like these, there's no bone exposed. The wound is smaller, 1 by 1 centimeter in size or smaller. You can clean the wound and you can manage it with semi-occlusive dressings. These will heal. It can take 6 to 8 weeks, but often a finger that's left to heal by itself has got a better quality coverage than putting a skin graft over it. Technically, even if the bone is exposed, as long as it's not skeletalized, in other words, you don't have a piece of bone sticking out, if the bone is flush with a soft tissue, you can probably still manage it with a dressing like this. Bigger wounds, you can also manage this with dressings, but it just takes a lot longer. But Injuries like these, I just manage with dressings. Nail bed injuries, I don't know how often you see these, but we do see quite a bit of it. If you have a nail bed injury, just remember the difference between the germinal and the sterile matrix. So the germinal matrix is where nail growth comes from. That's the proximal. And also remember, if you look at this, if you can see the cursor, the nail bed actually starts about over there. And from there to there is your germinal matrix. That's the one thing you really want to make sure it gets repaired well. But in my case, if you've got a cut through the finger, through the nail plate, and the nail plate is still attached to the nail bed, I just oppose the nail plate and I suture it with a 5/0 nylon. The 5/0 nylon needle goes through the nail plate very easily. You align the nail plate, the nail bed will also be aligned. If your nail plate is partially avulsed, so it's not attached to the nail bed anymore, you can remove the nail plate. And then you can just repair the nail bed, usually with a 6/0 Vicryl is fine. If you can still use the nail, I just reinsert it, not for nail growth, but just to protect the repair. If you've got no nail plate left, it's completely gone, and you repair the nail bed, you only really need to put a spacer in if the injury extends underneath the eponychial fold, which is this area. The reason for that is if you've got an injury underneath the fold, and there's no spacer in there, the eponychial fold will scar onto the nail bed and the nail won't grow out again. But if the laceration's over here in what we call the sterile matrix, you can repair it without putting a spacer. You don't need a spacer over there. I hope that makes sense. Okay, closed injuries. I'm going to go through a lot of closed injuries. And the reason for that is just a lot of these things are very small injuries. And you're going to think, we just see punga injuries, we just see this, we just see that. These injuries are really common, and if they're not treated correctly, they can actually cause quite a lot of issues. So the first thing, and this is very, very common, we call it the jammed finger and volar palate injury. So it is stable collateral ligament or volar plate injuries, plus minus a small fracture. So usually it's the direct trauma to the fingertip. They come in with a PIP joint that's swollen. Sometimes it does look like a boutonniere, and that's why we call it a seroboutonniere. These injuries you don't really want to immobilize. They should move as fast as they can. If that fracture fragment is large, it can affect stability of the joint. So always, again, just get your x-rays. Even if you think it's the so-called sprained finger, get them to do an x-ray. If that fragment is big, technically it can affect the stability of the finger. Just make sure you get a good lateral view and make sure the joint is congruent. Move them and then repeat the x-ray in 2 weeks. I'll get to some other injuries later on where it's also important. Jersey finger, it's not that common, but it's something you just don't want to miss. That's where people play sport. They grab onto a jersey of another player, and their flexor digitorum profundus avulses off from its insertion. So they cannot flex the tip of their finger. This is a clinical diagnosis, and ideally it needs to be repaired within 7 days. So you don't need an ultrasound. Sometimes the x-ray is handy because it can pull a piece of bone off with it and can help you with the diagnosis. But these injuries just need to get referred within 7 days. So just check carefully for that with finger injuries. This is incredibly common. You're going to see lots of these. It's your mallet injury. So what a mallet injury is where your extensor tendon tears off from the base of the distal phalanx, and patients present with this picture. This almost looks like a swannick, but it's basically a mallet as well. They can't extend the finger. Always get an x-ray, and I'll show you why now. The vast majority can be managed conservatively. They need to go into a mallet splint. If you've got occupational therapists that can help you, great. Otherwise, you can put a little pop around the finger. You don't even need to put soft band or ortho wool underneath it. You can just gently wrap POP around it with the finger in full extension at the DIP joint, and you must leave the PIP joint free so that can move. They've got to keep that splint or small plaster on 24/7 for 8 weeks. then they've got to wear a splint at night for another 6 weeks. Even if your treatment is successful, there'll always be a bit of an extensor lag. So very few patients will be able to straighten this fully, but as long as they've got active resistant extension, it's a good outcome. Your complication is if this doesn't get treated, is they actually get a Swanwick. And this is an early Swanwick, but this is an acute injury in a patient that's hyperlax, so it's not an issue there. Why you want to get the X-ray? So if you look at this X-ray, this is diagnosed as a mallet. There's the X-ray, there's a small fracture fragment. The fracture fragment is not the issue. But if you look at that, you'll see that the joint is subluxed. That's a subtle volar dislocation. You'll only pick this up on a true lateral. In other words, if you don't get a true lateral X-ray of that joint, this will be missed. Once you get an injury like this, it actually needs surgical treatment. So we always used to say that if that fracture fragment is bigger than 50%, it needs surgery, but it's not the size of the fragment that counts, it's the stability of the joint. And you'll only pick this up if you get a proper X-ray of that area. And I'll speak a bit more about just making sure you get proper X-ray. So that's really important. And as I said, stability is important in these joints. And you've just got to, if this happens, generally they need to be referred. This shouldn't be managed conservatively. Boutonniere deformities, a true boutonniere is very rare. So that's where your extensor tendon tears off the finger there. So you get your PIP joints flexed like this, your DIP joint goes into extension and it's stiff. Even these can usually be managed conservatively if you get them early. Once they're stiff, we also tend to manage them conservatively, but a stiff boutonniere probably needs referral. Acute boutonniere should be splinted in extension for 6 to 8 weeks. So again, if you don't have an occupational therapist that can provide a splint, you can do a small POP around the finger from there to there. You leave the DIP joint free and that they can move, but that's got to stay in extension for 6 to 8 weeks. How to test for your central slip if it's intact? There's two things I do. The one is you get them to extend their finger and you push on the finger to see if they can resist. They've got good resisted extension. And the other thing is you flex the finger at the PIP joint to 90 degrees and you ask them to push against your finger and you look at the DIP joint. If you can still flex the DIP joint with resisted extension, then the central slip is intact. And you might look at this and think, this is all very technical and this is not really, not really important to know. But the big thing is there's a big difference between a boutonniere and a jammed finger. A boutonniere's got to be splintered for 6 weeks in extension. The jammed finger must be mobilized. And I see a lot of people where they weren't managed correctly and they end up with painful stiff fingers and they can't work with their hands. And then it takes a long time to get them to a place where they can work again. You all know this from your orthopedic time. When you look at fractures, you've got to look at displacement, you've got to look at angulation, you've got to look at shortening, you've got to look at rotation. So rotation is a clinical diagnosis. So this is specifically in fingers, so metacarpals and finger fractures. Rotation is incredibly important to test for. Absolutely clinical diagnosis. It's not an X-ray diagnosis. Don't rely on the position of the nail plates. It's not reliable enough. So what you do is you flex the joint distal to the fracture. And I know it's difficult when people are in pain, but you can always just do a ring block and check. And then you look for overlap. So basically, if you look at a normal fist, all the fingertips are pointing towards the scaphoid tubercle. All right. If there is a fracture and there's rotation, one finger will overlap and it will not point towards the scaphoid tubercle. So this is your most reliable way of testing for rotation. Rotational deformity should generally be managed surgically. You can try and derotate it with a block and manage them in a splint and with a buddy strap, but it's very difficult monitoring rotation once you've put them in a splint. So proximal phalanx fractures, you can see there, this is something that you can generally manage conservatively. So most proximal phalanx fractures you will be able to manage. So what we regard as an acceptable position, less than 50% displacement is acceptable, less than 10 degrees of angulation, and less than 2 millimeters of shortening. We don't accept rotational deformity. That cannot be accepted. So what you can do, you give them a ring block, which is quite easy to do in the finger. You reduce it. I buddy strap then the finger to the adjacent finger. You just buddy strap that, but you can't just buddy strap it. You've got to actually splint them, either in a thermoplastic splint if you've got occupational therapists. If you don't, below elbow back slab, and I'll show you now what that looks like. And you've got to do check x-rays to make sure the position's maintained. So again, as I said, it's not just the finger, and do not just buddy strap it. Yes, there are certain fracture types you can, but in general, proximal phalanx fracture is better to splint it. And we're talking about adults here, of course. So when you look at a proximal phalanx fracture, the way the extensor tendon and the intrinsic muscles will pull on it, it will always tend to pull it in this position. So we call this volar apex angulation or dorsal tilt. So your deforming force will always redisplace the fracture into this position, unless you flex it. So if you flex the MCP joint to 90 degrees like that, and you keep the rest of your fingers straight, in that position, the fracture will reduce. So once you've given them a ring block, you can pull on it, you flex it, and while the block's working, you put it in a dorsal back slab where your wrist will be in a little bit of extension and your MCP joints will be flexed. And you can actually, with a dorsal back slab like that, you can allow them to flex the finger in that position. So they can actually move it. The only thing you must be cautious of is if you don't apply it correctly and you don't bandage the hand nice and tightly into it, obviously not too tightly, the hand slips out. And once the hand slips out, you'll see that fracture displaces. So, but this is definitely a way to manage proximal phalanx fractures. And actually, most of the ones I still manage like this, but I've got the advantage of an occupational therapist that will make the splint for me, but you can always treat it in a back slab. Your surgical indications is an inability to achieve or maintain reduction. So if you can't get it into a good position, or if you get it into a good position and it slips, then you'll go and fix it. Rotational deformity and open fractures we tend to fix. Metacarpal fractures. So this is a busy table, but this gives you a rough idea of what is acceptable. So we're looking here at angulation as seen on the lateral x-ray. So, and it's a logical way to remember it is that you accept more angulation in your little and ring finger than in your index and long finger. And that's because of the mobility of those CMC joints. You also accept more angulation at the neck than what you'll accept at the shaft. And that's just logical because a 40 degrees angulation proximal will cause a much bigger deformity distal than 40 degrees distal, if you understand what I mean. But basically, metacarpal fractures get treated surgically very rarely. Most of them can be treated conservatively. Surgical indications, as I said, the unacceptable angulation or displacement as discussed on the previous slide. That's on the lateral x-ray. On the PA x-ray, probably 10 degrees is acceptable. And then rotational deformity we'll manage surgically. Open fractures we'll manage surgically. And usually if you've got multiple fractures, it should be managed surgically. The reason for the asterisk is that if it's multiple metacarpal fractures and they're all well aligned, then you can attempt to manage it in a splint. It doesn't, or in a cast. It doesn't need to be fixed, but you just have to follow them up very closely. For instance, this is a nice long oblique, slightly spiral fracture. On the lateral, you can see the alignment is good. Clinically, there's no rotational deformity. So this gets managed conservatively. And how I manage it conservatively, I'll discuss now. So for me, metacarpal fractures, if it's not acceptable, I find it difficult to reduce them closed, and I find it difficult to maintain your reduction. So usually, if the position is acceptable from the start, the fracture configuration is usually stable and they're unlikely to displace. You've got to remember you've got intermetacarpal ligaments between your metacarpals. Those tend to stabilize it. So to infect, a fractured metacarpal is splintered by the neighboring metacarpals. It's not always true, but mostly. As you know, in medicine, you can never say always and you can never say never. So for conservative management, the academic answer is you immobilize the wrist in 30 degrees of extension and your metacarpal phalangeal joints in 70 degrees of flexion. And your interphalangeal joints are in full extension. Practically, usually when you manage a metacarpal fracture conservatively, the fracture is usually stable. So what I do is I just put them in a wrist brace or below elbow back slab, whatever you've got. I buddy strap the finger to the adjacent finger. It just helps with mobilization, and I actually allow them to mobilize the MCP joints. The reason for that is a stiff finger is a much bigger problem than a slightly malunited finger. But again, if you're going to do this, you need to follow them up with x-rays just to make sure you maintain your position. Just a quick word, boxes fractures versus a little finger metacarpal neck fracture. Unfortunately, I didn't have great photos of these cases to show you, but I'll try and explain it to you. So boxes fracture is a little finger metacarpal neck fracture, but it's a very specific mechanism of injury. Someone who hit something or someone, the fracture is quite distal, and it's usually impacted and stable, and they very rarely need anything to be done with them. I often don't even splint them. I just buddy strap them to encourage motion, and I let them go. A little finger metacarpal neck fracture, that's not a boxer's fracture. If there's a different mechanism of injury, then we're dealing with a neck fracture other than a boxer's fracture. They're slightly more proximal, usually. They're not impacted, and they're usually not stable. So if they are positions unacceptable, you must have a lower threshold for, let me repeat that. If that position is acceptable, you must have a much lower threshold for close follow-up to make sure that the position remains acceptable. Scaphoid fractures, also vast majority, can be managed conservatively. So the isolated waist fracture, if there's less than 1 millimeter displacement, they need to go into a below elbow POP for 6 to 8 weeks. You do not have to include the thumb, and 90% of them will unite. You can go and fix them. Surgery gives you a faster union, a faster functional recovery, and you don't need to immobilize them for a prolonged period of time. But in your setting, a scaphoid waist fracture can be treated in a cast. There's actually new research out, a big trial that shows up to 2 millimeters of displacement can be managed conservatively in a cast. So the vast majority, you can just cast them. If clinically you think it's a scaphoid fracture, and otherwise they tender over the scaphoid and the X-ray is normal, immobilize them and re-X-ray them in 10 to 14 days. If they still clinically you suspect a scaphoid fracture and the X-ray is still normal, it becomes a bit more tricky. In your setting, probably treat it like a scaphoid fracture and immobilize them for 6 weeks. But in my setting, we'd either CT scan them or MRI them. Just a quick word about the scaphoid fractures, just to be aware of. There's something called a DISI, which is a dorsal intercalated segment instability. And basically what that is, if you look at a lateral X-ray of the wrist, I've outlined the lunate and I've drawn the scaphoid for you on that. So when you actually overlap it, if the angle between those two, so you draw a line perpendicular to the lunate, the direction facing it, and one along the longitudinal axis of the scaphoid. If that's more than 70 degrees, then you're looking at a dorsal intercalated segment instability. The importance of this for you is just, if you see that, and normally what you will see is, and I'm just going to go back, it'll look like the lunate is pointing dorsally. If you see that in the presence of a scaphoid fracture, it means that the fracture is displaced a lot more than you think. It means that the fracture is probably flexed and they probably need surgical fixation. So seeing a lunate pointing dorsal, if there's a scaphoid fracture, probably means referral. If there's no DC and it looks undisplaced, you manage it conservatively. In acute trauma, if you see a DC and there's no scaphoid fracture, either you've missed the fracture or there's a scapholunate ligament tear. And I think if you can try and avoid the diagnosis of wrist sprain, always try and see anatomically what the injury is. And this is where knowing your anatomy is so good. If you examine the wrist, you will pick up where the pain is, and you'll be able to say, oh, the pain is where the scaphoid-lunate ligament sits, so it's probably injury there. Now, this is a classic X-ray of a scaphoid-lunate ligament injury. What I can tell you is that you usually, if you see this, it's either a devastating acute injury or it's chronic. You very rarely see this in acute injuries. This X-ray looks horrible. Again, complex carpal injuries, the main thing here is not to miss it. So the X-ray on the left looks horrendous. I'm sure you won't miss that. But sometimes you get these injuries, and this is what we call a transscaphoid perilunate fracture dislocation, that on the PA almost looks normal. But on the lateral, and this is what you must always look for, if somebody comes in with a really swollen wrist and you don't see any clear fractures, just look on the lateral. There's your lunate. There's your capitate. They're not in the same line, and they should be sitting in the same line. As soon as you see this, then you know there's actually a dislocation in the wrist. These, you can try and do a closed reduction acutely because these patients get acute carpal tunnel syndrome, but this needs urgent referral. These guys need urgent referral. So the big thing with this is just don't miss it. So distal radius fractures, probably quite controversial at the moment. Generally, acceptable parameters, shortening it up to 2 millimeters, and that's if you measure the radius with next to the ulna. So once the radius is more than 2 millimeters shorter than the ulna, they probably need intervention, but we'll accept up to 2 millimeters. Dorsal tilt, acceptable is up to 10 degrees of dorsal tilt. I personally prefer neutral, and I'll show you now on an X-ray what to look for. Radial inclination is acceptable as long as it's more than 10 degrees. And an intra-articular step, they talk of 2 millimeters. That's acceptable. I prefer 1 millimeter. The one thing I'll mention about this is there's a lot of research in Europe saying that patients over the age of 65, it doesn't matter what you do, their outcomes are equivalent. But technically, in your elderly patients, you don't have to stress too much. I personally feel it's still worth reducing it and getting the best position you can. In terms of whether they need surgery, very controversial. But there's a lot of literature that will support if you get a patient in their 70s or 80s, that you just need to roughly align it and then you immobilize them and that's fine. But again, remember age, we talk about chronological age, but technically we should look at physiological age. You get 80-year-olds and you get 80-year-olds. So this, for instance, distal radius fracture, you can see it's intra-articular, it's completely undisplaced. This doesn't need surgery, even if it is intra-articular. But again, if you do immobilize it, follow them up with serial X-rays. That's an intra-articular fracture, and there's a big step in the joint. This needs to be referred for fixation. This is a patient who came in with a distal radius fracture, and we talk about neutral. We draw a line along the axis of the radius, basically there, and a line across the joint space. That's borderline acceptable, probably about 10 degrees dorsal tilt. The serial X-rays for this case was not really done, and at follow-up, much later on, you can see it's actually worsened. So there's two things here. Serial X-rays weren't done, and they didn't apply a proper cast. So this is what you want to avoid if somebody comes in with the X-ray looking like that. So for distal radius fractures, depending on your facilities, you can reduce it under either sedation or a block, a Beer's block, a hematoma block, whatever you've got. But if somebody comes in and it's grossly displaced, try and reduce it. Put on a well-molded cast with 3-point pressure. If you think it's too swollen, you can do a volar or dorsal back slab, and that depends on which way the fracture went. If the fracture displaced dorsally, rather put on a dorsal back slab. Then do see them at 2 weeks for a position check X-ray, and then you can convert them to a circular cast at that stage. Just a quick note, I call it the poor man's CT scan. If you don't have access to a CT scan and you want to properly review the distal radius articular surface to see if the joint is okay, there's certain X-ray views you can do to help you. And you can ask your radiographers to help you get this. So remember your radial inclination, generally about 20 degrees. So this is important for the lateral view. So I talk about the 20-degree lateral. And you can see the difference. The left-hand side is an X-ray. That's just a normal lateral. It looks like the screws are in the joint. You can't see the articular surface. If you do the lateral by elevating the arm about 20 degrees so that the X-ray beam shoots right through the articular surface, this is what you get. And this is an intraoperative picture or fluoroscopy. You can clearly see the articular surface, and you can clearly see there's no screws in the joint. Obviously, for you, the screws are not important, but it's important to see that you can actually visualize the joint surface properly to see if there's intra-articular displacement or step. For the same, if you're doing your PA view, there's normally about an 11-degree volar tilt to the distal radius. So if you want to assess your articular surface properly, you just do a 20-degree PA, and that's the difference. You can see on the normal X-ray, there's your one articular surface, probably the dorsal one. There's your volar surface. Once you elevate it, they're almost lined up, and you can just get a better view of your whole articular surface. So that's just a way to assess your articular surface if you don't have access to a CT scan. Sepsis, somehow this didn't, I don't know what happened to that picture. It was there earlier. Basically, just with sepsis, the picture I wanted to show you there was of a diabetic hand. With sepsis, you need a very aggressive approach. Sepsis is very important. You're going to see a lot of this. Cellulitis of the hand is very unusual. Yes, you get little early scrapes with a bit of cellulitis. But be cautious of making a diagnosis of cellulitis. If you do think, if they present early and you suspect a possible cellulitis, treat them on antibiotics. But if there's no or minimal response in 48 hours on antibiotics, there is an abscess somewhere that needs drainage. If the patient presents 48 hours after onset of symptoms, strongly suspect that there is an abscess. Ultrasound is not reliable to pick up hand abscesses, especially flexitinosynovitis, as they can miss. So clinical diagnosis, and very, very important. If somebody's got hand infection, please don't put them on antibiotics for 5 days and reassess them. And if they're not better, put them on antibiotics again. The picture I want to show you is a patient that happened to, and she lost a finger. So please, if you see a hand infection after 48 hours of antibiotics, if there's no response, there is an abscess somewhere that needs to be drained. Don't put them on another course of antibiotics. Don't wait longer. They need to be referred urgently. Then just a couple of tips and tricks. In terms of splinting and casting, if possible, always leave your metacarpal phalangeal joints free for motion. I'll show you a photo of that now. Unless there's a good indication, if you do need to splint the MCP joints, never splint them in extension, okay? If there's extensor tendon repair, that's different. But in your setting, don't ever splint them in extension. They get stiff very quickly. So your best position for the hand and wrist, which is a functional and safe position, slight extension at the wrist, MCP joints flex to 60 degrees, and your interphalangeal joints all on extension. That's your safe position. That's the best position to be in. When you do your splint or cast, just look at that. The distal palmar crease should be free. This is a volar slab. That should be free. And a patient... Oh, I've lost a lot of photos. Let me just check quickly. Okay. I'm going to probably, because this is pretty important, if you give me a second while you talk, I'll quickly see if I can just download them and we can have a look at them. But basically, finger tourniquet, I'll show you now. If you're working on a finger or you're suturing it or you're doing anything, you can put a finger tourniquet on. This is one of the safe options. That one is not a safe option. I'll show you that now. And then remember, you can use a local anesthetic in the hand, and you can do most things under block, depending on what you're comfortable with. And remember that adrenaline is actually safe in the finger. You can use adrenaline in the finger, you can use it in the hand, but you've just got to check for other contraindications. So somebody with peripheral vascular disease, you're not going to use adrenaline. Somebody with Raynaud's, you'll avoid. Somebody with Crest syndrome, you'll avoid adrenaline in the finger. But generally speaking, in the hand, you can use adrenaline with lignocaine. It is safe, and there's a lot of research to prove that. Last word on x-rays. when you ask for x-rays, always ask for the x-ray of the anatomical area you're investigating. So in other words, if the thumb is injured, ask for a thumb x-ray. Don't ask for a hand x-ray. The same for the wrist. If you think there's an injury to the distal radius of the wrist, ask for a wrist x-ray. Don't ask for a hand or a forearm x-ray. And make sure you get proper views. In the hand, it's quite important. You will miss injuries if you don't get proper x-rays. So ask them for a true AP and a true lateral of the area you're interested in. And to show you here, if you, and it's just a simple diagram to explain. Remember, x-ray beams are divergent. In other words, the only area where you get a true image here, in this case is a lateral, is of this area. Even though you can see the wrist on a forearm x-ray, you don't get a proper view of the wrist because of the divergence of the beam. So if you are interested in the wrist, ask for a wrist x-ray. So in conclusion, I think know your anatomy, do a thorough clinical exam, and actively exclude injuries to all the structures which can be injured, so that you don't miss injuries. Have a very low threshold for x-rays, and actually just get x-rays. It's just safer. You can treat the majority of closed hand injuries conservatively, but beware of exceptions. And if you're going to treat fractures conservatively, just follow them up with serial x-rays to make sure they don't displace. Majority of your open injuries should be referred, especially if there's injuries to deeper structure. But again, I mean, if it's an open injury and you can exclude injury to your deeper structures, then you can wash and suture it. You don't have to refer them all, and immobilize in the correct positions. Sorry, that's a mouthful. What I can do, Madeleine, if you give me 2 seconds, I can just actually see if I can find that the picture of the
Yes.
tourniquets, because it's
No problem at all. There's a question actually in the chat that came up early on,
yes.
asking around multiple digital nerve injuries. Do you usually repair all of the digital nerves or specific ones? For example, the ulnar side of the LF, radial of the MF stroke IF.
Yeah, so I like nerve work, so I'll repair. So if I go in, I repair all of them. But if you critically look at it, if you critically look at it, technically both thumb digital nerves are important. Your radial digital nerve of the index finger and your ulnar digital nerve of the little finger. Those are your really important ones. But in my setting, I repair, if it's multiple injuries, I repair all of them. And if I can't repair them, I graft them, if that helps.
Great. Are you?
Let's just see.
Welcome.
Let me just quickly see if I can share that again.
You should be able just to share a photo. And then there's also another question in the chat here. Do you recommend that all human bite injuries on the hand be admitted or referred on the same day to the orthopedic surgeons? So human bites on hands, that's quite common.
Yeah, so something we don't see often in private practice. But basically, sorry, this thing is frozen on this side. I'll see if I can get it on later again. But basically, human bites, it depends on what's injured. So a typical fight bite, I think, so somebody hits someone and they've got a tooth mark that's close to the metacarpophalangeal joint. I think that should be washed out if you suspect that it's entered the joint. That should be referred. If it's just a bite somewhere else and you don't expect deeper injury and you can wash it out and put them on antibiotics, get your x-ray, make sure there's no fracture. Obviously, if there's a fracture, that needs to be referred. If there's no fracture, the tendons are intact and didn't go into a joint, then clean it and give them Augmentin. The same with dog bites. I'm happy if you don't suspect deeper injuries that you can just wash it out and treat them initially on antibiotics. But it all depends on how deep it is and what other injuries, what other structures are injured. That's the big thing. But I don't, as I said, thankfully in private, we don't see many of these anymore. But classic fight bite, where you think the tooth has gone into a joint, you have to actually go and wash that out.
Thank you very much, Peter. People are also welcome either to put their hands up or put more questions on the chat. But I must say that was a wonderfully, very wide range of things that you have covered there. And I think it's just helpful, as you've said, to not just have the automatic, oh, it's just a finger, I'll clean this and put a buddy strap on it and hope for the best.
Yeah.
I think being willing to call up an orthopedic surgeon, if you're out in the periphery and you're not sure, send a picture to a friend, and get a little
Mm.
bit of an idea of how much risk you can take before you just make a
Mm.
decision on what to do with a hand injury.
Yeah, I think the important thing for me is just that and it's like most things, you know, your first bite is your best. So reconstructing an injury later or re-breaking and doing an osteotomy and things like that is much harder than just managing it right from the start. But again, I mean, you guys in a position where you're rural, you can't refer um, you can't refer people all over the show constantly. But I think if you can kind of make contact with somebody in your area that you refer to that's happy to just give you advice, there's nothing wrong with asking for advice. Um, just to make sure that you don't end up getting patients who struggle later on. But what I can also say, um, for me, it's about pain and function. So even a finger that's skew, if somebody's got good function and they don't have pain, it's not an issue. Your issue is somebody who cannot function, who's got chronic pain. That's where it becomes a problem.
I mean, there's a question on the chat. We're very happy to have the occupational therapists here as well, asking. So it's an OT working in a very rural hospital where they get referrals
Mm.
for a lot of outpatients post-fracture or injury where it's clear management was not done correctly. Patients often have deformities, limiting range of motion, decreased strength, and pain with movement. What would be the red flags to look for to know what needs to be referred back for clinical medical treatment and what would see improvement with rehabilitation? It's quite a broad question, but if you could give a few points.
Yeah, sure. That's a difficult one. I think so. First thing is, you know, is the fracture united or not? I think it depends on what stage you're talking at. So if they've gone through the healing phase, I'd always just first rehabilitate them. I mean, if it's quite a, yeah, it's a broad question, but for me, I look at the patient. So if the patient is in pain and they're really struggling, then refer them back. I mean, there's usually a reason for pain. Usually it's either that the fracture is still unstable and it's not united. Stiffness, though, in the absence of pain, even if there's deformity, if a fracture is clinically united, then I would first mobilize them. It's incredible how well people adapt, and it's incredible how functional they can be. So if their pain is settled, try and rehabilitate them and get movement back and see how functional they are. I saw a kid yesterday with a malunion of his finger, and I looked at it, and he's so functional. I said, just leave it. You don't have pain. You can do what you want to do. Just leave it. Because revision surgery or surgery often leads to stiffness. If it's tendon injuries, then you've got to, let's say they've repaired a tendon that you follow up. Then the issue is the repair intact or not? Uh, um, if a patient, if you suspect the tendon repair is ruptured, it's much easier fixing that early than going back to fix that late. And in case of nerve injuries or possible nerve injuries, if they've got neuropathic, you know, it's always a good idea to try and manage that conservatively first before you go in and do surgery for it. But again, it depends very much on the situation. It also depends on how open your surgeons or are to referring back to them. Depends a lot on your relationship with them. I mean, I mean, I know this is a different setup. We've got a setup where the occupational therapist's office is next to mine. And if my door's open, she just walks in and says, look, she's got this. She's worried about it. What should we do? If you don't have that situation, you're rural and you're not close to where your surgeons are, it's a bit of a different story. But yeah, I don't know if that really answers the question, but it's going to be very patient and condition specific. But
Yeah,
usually
thank you very
pain is
much.
a red flag.
That's very helpful. Yeah, there's also a question. It's actually from my neck of the woods here at Cecilia Makiwane Hospital. It's a very large regional hospital, and
Mm,
in Tanzania, and see a lot of violence. And one of the
mm.
docs there are asking that they get a lot of cases of community assault. And is compartment syndrome common for the hands? And how do you manage very swollen hands due to community assault without the presence of fractures? So they use these soft pipes and things to hit people
Yeah.
over.
So I think the first thing is compartment syndrome of the hand is not very common. It is rare. The forearm is probably more common than the hand, but it's not common. You don't see it that often. Um, But the big thing, and it's a purely clinical diagnosis. So your first sign is increasing pain despite adequate analgesia in the presence of a tensely swollen compartment. So that's absolutely a clinical diagnosis. So if somebody presents to you and they've got this severely swollen limb and the compartment's tense and they've got increasing, I talk about crescendo pain that's not responding to analgesia, that's when you suspect it. And then pain on passive stretch is the next big thing. If you get pain on passive stretch in combination with that, then you suspect a compartment syndrome. If it's a compartment syndrome, you need surgical release. There's no way around that. They need a surgical release.
Oh dear, I'm not sure. Peter, I think we just lost you. You were frozen for a moment and we lost you sort of mid-sentence, but only for 10
Okay, is
seconds.
that better?
There we go, you're back.
Yeah, so compartment syndrome is incredibly rare in the hand, and if it's there, it needs surgical release, definitely. So they need surgical release. If it's just very swollen, your occupational therapists are incredibly useful in sorting this out. So that's where if you're in a hospital, you've got OTs or physios, they're very good at edema management, but elevation, very important. Um, but often, I'm not a big fan of putting them into these pillowcases. The reason is one, it's very uncomfortable, so compliance is often not great. Two is if you put them in a pillowcase, you end up flexing their elbows, and your big veins run through the cubital fossa. And if you flex your elbow, you end up kinking those veins, which often means your swelling does not improve that much. So I'm not a big fan of that. What I do is I just elevate the hand on pillows above the heart. That's very important. Then intrinsic hand motion. So activating your intrinsic hand muscles, very good for swelling. That really helps get the swelling down. And just movement and elevation. So that's what we do over here. And then I get the occupational therapist involved.
Thank you very much. Peter, are you winning with finding your pictures? Do you want to try and
I,
share again?
I'm going to try and see if I can share it, but somehow I've got a bit of I'm just going to close this. Let's just see if I can share it quickly.
Sure.
Okay, let's see if I can. Okay, let's see. Okay, let me just try and see if it'll work now. Can you see that, or is it? Oh goodness, I've got a complete technical failure on this side. Sorry,
So
Marlene, it seems.
we've just got a black screen.
Okay, no, sorry about that. I think there's a. Let me just try once more.
If you do have any other resources later, even like a video or something around that, or photos, I can also share it later on the group or on
Yeah,
the.
I might send it to you. It was all working
We can
beforehand, so I'm
send it
not sure.
round. That's not a problem. But yeah, at the moment, it's not appearing.
What are you seeing now? Nothing. It's gone completely. I'm not sure what's happened. Sorry about that. But what I can do is I've got the talk. I'll send it to you. But basically about a finger tourniquet, I'll try and explain what I do and why it's important. So with finger tourniquets, a lot of people, what they sometimes do is they take a glove and they cut off a finger of the glove and they roll it onto the finger. It works amazingly well because as you roll it onto the finger, it exsanguinates the finger and it gives you a bloodless field, which makes it very easy to work on the finger. The issue with that is you've got a glove, a small little glove that's just around the finger there. People forget about it. And I've seen patients where the tourniquet was left on the finger and the finger's gone necrotic. So I do two things. Either, and that one photo you saw, you could see it. What I do is I cut I cut the fingertip of a whole glove, just the finger off of the finger that I want to work on. I put the glove over the hand and I roll that specific finger up. So the patient's got and that photo you actually saw, you've got a glove over the whole hand with this finger exposed. You're not going to forget that glove on the patient's hand, and the patient also won't forget it. So that's one thing. The other thing I do is I cut the finger off the glove. I wrap it around the finger and grab it with the artery forceps. I twist it up till it's under tension, and then I clamp it with another forceps. It'll give you a good bloodless field, and no patient's going to walk out of casualty with artery forceps attached to the finger. They'll notice it's there. So it's just for safety, so you don't forget the tourniquet on. But honestly, use a tourniquet if you want to work on the finger and it's bleeding and you can't see what's happening. And feel free to use digital nerve blocks to give pain relief so that you can examine the hand better, that the patient's more comfortable and you can see what's going on and you can clean it properly.
Thank you very much, Peter. We're doing very well for time. We're just exactly on 6:30 now. I think there's one last question. So two questions by the same person. The first question is a volar slab only for distal radius fractures, or is it appropriate for distal third to fifth metacarpal fractures? And then the second question is, how early is it appropriate to refer hand fractures to the OT for splinting and hand OT post back slab application to prevent stiffening?
So you can use it for metacarpal fractures as well. So again, for me, that's the same thing, the volar slab. If the fracture is in a good position, it's probably stable. So if it's stable, you can leave your MCP joints free and they can mobilize, and you can put the volar slab on like that and they can move it. If it's a metacarpal fracture and you are concerned that it might be unstable or it's multiple fractures, but the position is good, then you can extend the volar slab all the way to the fingertips like that, in that position. Or I'll get it across like that, in that position. And then the volar slab goes all the way. But if it's let's say it's a middle finger metacarpal fracture, like the one I showed you, that's in a good position, volar slab up to there and they can move. That's fine. How early do you refer it? As early as you can. If you've got, and it depends on how close your OTs are to you and what your relationship is with them. Basically, if I reduce a fracture in the rooms, I refer to the OTs immediately. While the block is still working, I get them to splint it. If I have a distal radius fracture that I manage conservatively, if I see the patient struggles with finger motion, I refer to them immediately to get the fingers going, because at the end of the day, with a distal radius fracture, flexion, extension, radial ulnar deviation, if they lose a bit of that, it doesn't bother patients that much. What they do miss is finger motion and rotation. And you can get some rotation going with the back slab on. You've obviously heard about CRPS. There's a lot of controversy about complex regional pain syndrome. Casts that are too long, that are too tight, that are on for too long are all implicated in chronic regional pain syndrome. So that's where I think keep your MCP joints free. If let's say it's a distal radius, keep your MCP joints free and get them moving, get them rotating as early as you can. And obviously, if it's a distal radius fracture, you mobilize the wrist. As soon as you come out of the back slab, refer them to occupational therapy for range of motion. You're not going to move a wrist that you need to immobilize. But as soon as you can take them out, you can actually mobilize them.
Peter, thank you very, very much. I think that is all the questions. And yeah, we can already see very good, very excellent feedback in the polls in terms of the usefulness and for an excellent presentation, really nice, proper, like practical hand clinic. And we hope we can get you back in the future for some other orthopedic topics, because I believe you don't only do hands where you are at, you're also in the rest of orthopedics still.
No, actually just hands and nerves.
Okay,
that's
if
all
you
I
manage
do.
to now just get into the hand field.
Just hand, wrist, and nerve, basically. Yeah.
Okay, very nice.
A lot of nerve work, a lot of wrist work. Look, you've got I'm happy to, if you've got more questions for people to contact me, I don't mind that. Obviously, I can't field all the acute cases constantly, but I mean, people are welcome to contact me if they've got questions. You've got my details, and I'm happy to answer questions as well.
I think one way of doing that is actually having an email address of you rather than a telephone number. So that
Yes,
if people want to
yes.
discuss a case, a chronic case that they're working with, that makes more sense. Their acute
Yeah.
cases they need to discuss with their own referral teams,
Yes, yes,
because that'll also
yes.
be more appropriate. But in terms of
So,
chronic cases, certainly, yes, I think
yeah,
that would be very helpful.
yeah.
Thank you very much. Thank very much, everybody. Next week, we'll be doing polytrauma, and then our last week will be on ethics. And thank you very much for attending this evening. And we all hope you have a little bit of relief from the heat in the week to come. Thanks very much, Peter. Have a lovely evening.
Yeah, you're welcome. Thank you, guys. Have a good evening.